Wonderful. So let me share my screen with you guys. So once again, thank you very much for all your kind words. Keeps me motivated anyway, and I'm trying my level best and push myself hard as well. So most of the people knows everything, but let me go quickly, directly jump to the main stem of the things today. This medical MCQ for all. As you know, we provide everything including book, website, viva, coaching, subscriptions, short, short, and everything. So you can inquire later on. I myself, Dr. Munjal, hemato-oncologist and transplant fellow, practicing almost close to 20 plus years and deliver thousands of lecture and treated 100,000 plus patients. So probably my experience will reflect in my lecture probably. Yeah, and I'm also member of American Society of Clinical Oncology, flying US every year on May, June to just get myself updated at Chicago, Illinois. This is Dr. Arthi, who is also a gold medalist, consultant pediatrician in my hospital earlier. Now she joined the new hospital, but she is very close to me. Dr. Madis, as you know, is a brilliant speaker again and very knowledgeable lady. Dr. Ankit is little I mean busy nowadays, but he's an excellent gastroenterologist. So I will come on the board very soon. Dr. Shikha again started taking lectures for us. She's based at Dubai, and your team as a consultant gynecologist. And recently, three doctors has been joined. Dr. Islam, who is a surgeon. Dr. Mariam Hilat from US. She is in New York in a resident of neurology, and Dr. Sonal Shah, who is a consultant emergency physician at Jaslok Hospital in Mumbai. It's one of the reputed hospital in India, and lot more people are joining. This is, as you know, Dr. Deepali, Dr. Ankit, Pallavi, everyone knows, right? She's calling you, Dr. Anjali, as data flow. So this is the things, and once again, I would like to stress on the things. Those who are still not sincere about the mock test, go and do the mock test. Every time I'm telling, go and do the mock test. Maximum mock test you do, maximum mistake you will get to know what and where you are doing the mistake, and try to concentrate on your weaker parts rather than doing the subject which you knows more. Right? Whatever you knows, but try to strengthen the weaker areas. That is a area where you improve your score from 50 to 60, 60 to 70, 70 to 80, whatever you are getting, right? But try to do the maximum mock test probably once a week, at least once a week or twice a week. If you get more time, I would be glad and happy. So there are various, again, those who are little earlier worried about the financial part. So the job makes very easy now. It's very much discounted. This is one of the best package I can little highlight here. You can inquire later on, right? But just this is the most important popular 40 hours coaching, right? It's supposed to be 905, it's just only 350. So you can inquire later on, we'll guide you, and you get almost this all 10 things free in the same package, right? So everything you will get, right? Nothing is left. So you don't need to struggle for material and study material when we are pushing so hard for you guys. You just need to prepare just 2 months, 3 months, that's all. So, and last but not the least, this is our mobile application, excellent on the Android and iPhone. So, those who have not downloaded so far, you can completely serve the whole website on the Android as well as on Apple iPhone, right? Complete website you can download on the mobile. You can see complete website as well. So, it's a compatible, excellent, recently updated with the look and speed. So, earlier it was little problem in the speed few, so it was also sorted out. So let's start with our main things. Get self ready and interact with me. That would be the great learning. Today we are discussing 10 questions, but close to 50 questions I will going to cover in next 1.5 hours. So let's start. First questions in front of your screen. 76 years old woman is brought to the emergency department by her son because of 1 day history of upper abdominal pain, nausea, dyspnea. She was diagnosed with the inferior wall MI, means inferior wall myocardial infarctions 3 days ago, and was treated successfully with the coronary stent placement. She lives alone since her husband died 2 years ago. Her medical history is significant for type 2 diabetes mellitus, recently diagnosed Alzheimer. Her medications include aspirin, clopidogrel, atorvastatin, metoprolol, lisinopril, and metformin. The son reports that she has trouble remembering to take medications regularly. She drinks 2 to 3 glasses of wine daily. She is alert and oriented to person and place, but not to the time. Her temperature is 36.9 degree Celsius, means 98.4 Fahrenheit. Pulse is 59 per minute. Respiratory rate is 17 per minute. Blood pressure is 145/77. Physical examination, so no other abnormalities. Which of the most likely to establish the diagnosis? Measurement of serum lipase activity, serial measurement of serum troponin concentration, CT angiography of the abdomen, echocardiograph, CT pulmonary angiography, esophagogastroduodenoscopy. Take your own time. We are not in hurry, right? We need to understand everything, right? Today's questions are little complex than previous, little, but it's important. In exam, they can ask you anything. So those who are joining me first time, or this is the triad from my side, MCQ. Three things you must know. What's the diagnosis of the stem? So first, you need to make a diagnosis. This is a tip for all the MCQ, not one MCQ. You must know investigation and you must know the treatment. So three part you absolutely know for each and MCQ, whatever you are solving from today onwards, you need to ask yourself, what is the diagnosis of this MCQ? How you gonna investigate this patient and what's the treatment? These are the three main questions asked in the exam. So don't stuck to they just ask you the diagnosis. Probably here they ask you the diagnosis, but they may ask you the treatment. They may ask you what is the best initial or best highest sensitive and specific investigation for this. So try to do a practice from today onwards in this way. So now this is open for all. Anybody wants to discuss, any chat box is open for everyone. So far there is no answer in the chat box A B C D E F, so you can post your answer. You can, this all questions comes in exam, so don't take it lightly, right? And every time you won't get a lollipop questions, one liner questions, never a one liner questions. Dr. Amutul has recently cracked the exam, so at the end of the session she probably share her experience as well. But meanwhile, my experience of last many years dealing with DHA is a scenario based question. So think over it, what's the diagnosis? So first of all, get me the diagnosis. Yes. Yes, Adil, any comment?
Sir, I'm thinking because there are two, I'm confused between two options because she has 1 day history of upper abdominal pain, nausea, and also shortness of breath. And 3 days ago, she had her inferior wall MI stent placement for that. And she is irregular with her medications. So it could be a case of pulmonary embolism.
So, your is pulmonary embolism. So now today onwards, doctor, I'm very happy at least you are interacting. And believe me, once you interact, you never ever forget any concept what I'm teaching you.
Yes,
So now
yes.
tell me pulmonary embolism, right? What point favors? Always remember this is all today's lecture is brilliant. What point favors? What point not favor PE?
Hmm.
This is what you everyone has to do this practice every day, every MCQ, not this MCQ, every MCQ. So you are giving me the pulmonary embolism as a diagnosis, right?
Hmm.
So what
Yes,
point favors in this scenario? Read whatever you are telling me, what favors. There are few point favor, there are few points not
yes,
favor. Not 100% point will favor, right?
yes,
So what
yes.
point favors for the pulmonary embolism in this case? Now go one by one. Probably you
So
can
the
start with age or presentation or risk factor or finding or clinical findings, sign symptoms, ECG findings, enzymes. What favors pulmonary embolism in this case?
sir, the first thing is she has a history of dyspnea, which is one of the symptoms
Okay, so
of
let me
PE.
write make a list. Dyspnea. Okay, dyspnea. Fine, fine, fair enough.
Yeah, and she underwent stent placement 3 days ago.
So MI and stent.
Yes.
So do you think patient who already had 3 days ago acute myocardial infarctions, basically inferior wall MI, they develop within 3 days the pulmonary embolism? Do you think so? How many of you have seen the patient who has a acute myocardial infarction and within 3 days pulmonary embolism? So far,
Not
one or
very
two I
often.
see. Not
Yes.
very often or very rare. I can say very rare,
Yes.
right? Very rare, right? So
Yes.
now let me tell you the pulmonary embolism. These are the absolute high yield point. Pulmonary embolism never ever develop without a risk factor or predisposing factor. What are the
Mm.
predisposing factor? First is deep vein thrombosis, lower limb surgery, prolonged immobilization,
Immobilization.
thrombophilia, thrombophobia, underlying malignancy or cancer,
Mm.
right? These are the absolutely a risk factor for development of pulmonary embolism. So none of them is there in the scenario number one. 76 years is quite difficult age. A fracture is also the
Mm.
lower limb fracture, right? Lower limb
Yes.
fracture, and
Yeah.
because of that, there is a immobilization, right? So
Mm.
they are more prone to get the pulmonary embolism. Now, this is a risk factor. So, reasonably, there is no risk factor, isn't it? Yes or no?
Yes.
Second thing is that in physical examination, I mean, in symptoms, how the pulmonary embolism present? Dyspnea. So there is a one symptoms only, dyspnea. It's fine, right? But they don't have upper abdominal pain. Number one, they don't have upper abdominal pain, right? Usually, they don't have upper
Mm-hmm.
abdominal pain, right? Number two, usually dyspnea, respiratory rate should be usually high. Here it is normal. 17 is normal, if I'm not wrong, right?
Yes.
There is a dyspnea, tachycardia, tachypnea. So there is no tachycardia, number one. So less likely, no tachypnea, no tachycardia, pulse is normal, no tachycardia, no tachypnea. Is that clear? Yes or no?
Yes.
Right?
Yes.
Number two, right? There is no tachycardia. Tachycardia is this all are exam question. Huh? If you concentrate, each and every word is exam question. Tachycardia is one of the most important clinical finding or ECG finding in pulmonary embolism. So this is exam question in DHA hard MOH, right? So what is the most commonest finding in ECG in pulmonary embolism? Tachycardia, right? And
Tachycardia.
second is
Yes.
S1 Q3 T3. If you have word this S1 Q3 T3, it is less seen on the ECG. What do you mean by S1 Q3 T3? Right? In lead 1 S wave, in
Yes.
lead
Yes.
3 Q wave, and lead 3 T wave, if it is present, it is pathognomonic. The word is pathognomonic. Pathognomonic. Pathognomonic means 100% confirmed. It is P, right? This is what the pulmonary embolism. Another thing, chest X-ray. How the chest X-ray in pulmonary embolism? Chest X-ray initially it is normal. It is normal, and chest examination is absolutely normal. So this is a very high yield point. You have a breathlessness, but chest is clear. You have a breathlessness,
Mm.
but chest is clear. You have a chest, right? You examine the chest, but chest is clear. So you cannot find anything in chest examination. While you are putting a stethoscope on the lung, you can't see rhonchi, you can't see reduced air entry, you can't see hyper resonant, you can't see crepitation, you can't see anything in the chest. Chest is absolutely normal, like you and me. Is that clear? Yes or no?
Yes.
Yes, sir.
Yes or no? Right?
Yes, sir.
So these are the possible things which you gonna look into any pulmonary embolism patient. So overall, so far what I'm seeing, nothing matching these things, right? Nothing matching these things, right? And so this is pulmonary embolism is less likely in this patient. And now right? So say for example, you are thinking pulmonary embolism. So what test you will do from this, the list? This is
From the
not
list, it
pulmonary
will be
embolism.
CTPA.
CTPA. Okay, fine. So CT pulmonary angiogram would be the one of the most sensitive and specific test for this patient, right? So now let's move our clock forward. This is not a pulmonary embolism, then what it could be? I excluded. So you must exclude when you give any diagnosis. You must exclude that. Okay, this is that. This is not that. So what is a diagnosis? Can't you think that
Sir,
acute
Pa-
acute myocardial
Restenosis, sir.
infarction?
I think it could be acute pancreatitis because the patient has history of 2 glass of wine daily, and she also
Let's
have history
discuss
of
acute
diabetes.
pancreatitis. Let's discuss acute. So pulmonary embolism is gone, excluded. Now acute pancreatitis, it's excluded. Now you tell me, doctor, what point favor and what not point favor. You tell me favoring point, I will tell not favoring point. Okay? Not favor. I will tell not favor, you tell me favoring point. This is learning. We don't need to mug up. We don't need to mug up. Now tell me, doctor, Ishra, tell me what point favor from the scenario, from the scenario. I'm not getting your voice. Probably there is some disturbance in your voice. Can you adjust your mic, please? Yes, now speak up. Yeah, we can see, but there is a very low voice. Probably your mic is away from your mouth or something wrong. You can
Hello,
readjust.
am I
Yes, no.
am I audible,
Absolute
sir?
fine. Very nice, very nice. Go ahead. Point favoring from the
Yes,
scenario. What point favor the acute pancreatitis?
history of upper abdominal pain,
History of upper abdominal
nausea,
pain. Okay, upper abdominal pain. Okay.
and
Not
she
point
also
favor.
has history
Okay,
of
go ahead.
wine, 3 to 2 glass wine per day, sir.
Okay, wine.
Alcohol,
Fine. Fine. Fair enough. Okay, I'm writing wine.
and also she also have a history of DM, which also leads to somewhat pancreatitis, sir.
Diabetes mellitus is a risk factor. Okay, fine. What else?
Mm.
and she's
Um,
also not compliant with her medications, if that contributes.
yes.
So, not compliance and pancreatitis, how it's reacted with each other. Because he is taking clopidogrel. Aspirin is antiplatelet. Clopidogrel
Mm.
antiplatelet. Atorvastatin antilipid, right? Or cholesterol. Metoprolol, anywhere lol is beta blocker. Pril is a ACE inhibitor, and metformin is a biguanide. So if this medicine, if or she is not taking, how does it will interact with the or related with the acute pancreatitis?
Mm.
If somebody is not taking this medicine, because this medicine is a very common, 1 out of 6 Indian is taking this medicine, believe me, right? Aspirin, clopidogrel. This is absolutely very common drug. So if they don't take this drug, they develop acute pancreatitis. That is what you mean to say? I'm trying to understand. Okay, so now point against by my sense. Why does somebody develop pancreatitis at 76 years of age? Number one, pancreatitis. Why this patient has a history of myocardial infarction, right? Why this patient does not have elevated amylase or lipase? Why this patient does not have any history of past this colic or stone in the gallbladder? Why these patients other findings? Acute pancreatitis, they usually have tachycardia as well, they have a fever as well, they have high count as well, leukocyte also as well. In the ultrasound or CT scan of abdomen, they may have a cyst or pseudopancreatic cyst or inflammation of pancreas, right? That is all, that should be also there, na? That is nothing is there in the scenario. So how did we get
Mhm.
to know? And somebody who developed the myocardial infarction just 3 days ago, why he developed the acute pancreatitis within 3 days? Why he develops? I mean, what's wrong? I mean, what's wrong?
So,
Upper abdominal pain, nausea, and dyspnea can be a symptoms of inferior inferior MI,
Mm.
right? So inferior MI, right? You go and read the chapter of inferior MI as well. What
Okay,
happens
sir.
there? Inferior MI, let me give you the idea. We don't need to mug up, right? So this is a heart, right? This is heart. Inferior MI. This is SA node to AV node, and then this is left bundle branch, right bundle branch, and then Purkinje fiber. right? This is general for your understanding. I'm putting it down here, right? So inferior wall MI is this is inferior wall MI. Here supplied left coronary artery. Inferior wall and posterior wall is supplied by right coronary artery. Major fatal worst prognosis is a S1, I mean lead 1, lead 2, lead 3, lead 4, lead 5 and lead 6, right? So there are six leads, or you can start the lead one, two, three, four, five, and six apex of the heart. This is how we put six lead, right? So SALI, this is what SALI, SALI, SALI. Remember SALI, right? Septal, lead one and lead two, septal, lead one and lead two, septal. A lead three, lead four. I mean, these all are the chest lead basically. Chest lead, right? There are six chest lead and six limb lead. Six limb lead. Lead one, two, three, AVR, AVL, and AVF, right? So this is all applied on limb. This is applied on chest. So chest lead six, limb lead, or total 12 lead. So we called as a 12 lead ECG. We take the 12 lead ECG. So here in chest lead, septal, anterior, and lateral, and inferior is 2, 3, and AVF is inferior. So first word of all, septal, anterior, lateral, and inferior. It is shortly cumulative tell as a SALI. This is acronym SALI. So septal, if there is a something, this is question in exam, right? Patient has a right lead one, lead two, chest lead one and lead two, ST elevation. Where is the problem? Septal. Lead one to lead four. Where is the problem? Right? So septal and anterior. So this is supplied by the left coronary artery. You can see, no need to remember. This part is left coronary artery. Only inferior wall is inferior and posterior right coronary artery. This heart, right? It's in the this is apex of the heart, right? It's nearby the epigastric region. So whenever epigastric pain is there, you must not miss three, four differential diagnosis. Epigastric pain. Can anyone tell me what are the differential diagnosis of epigastric pain? When
My
somebody
ulcer.
comes to you, so one is a peptic ulcer, okay, or gastric ulcer, better. The word is gastric ulcer. Right. What else? One is
MI.
peptic gastric ulcer. MI is especially
Pancreatitis.
inferior wall MI. Inferior wall MI mimics and you high chance that miss because they present with the epigastric pain. Epigastric pain, you feel something wrong in the
Reflexes
stomach,
of
something wrong in
reflex.
the pancreas. So pancreatitis is also a differential diagnosis of epigastric pain. This is how you have to explore. Now, one more question: how you differentiate epigastric pain of MI and epigastric pain of acute pancreatitis? By examination. By examination, how you know? Without doing the test, how do you know that, okay, sir, this is acute pancreatitis, this is inferior wall MI? Without doing any single penny test, how you get to know? Tell me.
Pain
ECG.
perceived on leaning forward, sir, on exam.
That is little surrogate. Leaning forward probably may have pain, may not have pain, but something which is sure shot or most likely. So here the clue, clinical knowledge will comes. Myocardial infarctions, epigastric region. If you palpate, if you press, if you palpate, there is no tenderness, and this is epigastric, mid epigastric or epigastric tenderness is plus. Why? Because in epigastric region there is a pancreas just below the inferior wall. There is a pancreas. So cardiac pain, irrespective of anything, whether you forward, whether you bend, whether you jump, whether you don't jump, whether you deep breathe, you don't deep breathe, whether you lateral, whether you right lateral, left lateral, nothing change the acute myocardial infarction. They are keep going pain in any condition, deep breathing, not deep breathing, understand? So aggravating, not aggravating, nothing. Cardiac pain is worse pain, right? It will not have any positional change. It does not have change in the inspiration or expiration. It does not have tenderness. So when somebody comes with the left sided chest pain, again left sided chest pain, right? How do you know this is myocardial infarction? How do you know it is muscular pain? Muscular pain has a tenderness. Myocardial has no tenderness. Whether you palpate or not palpate, there is a pain. But in costochondritis, muscular pain, myositis, when you press the chest, oh, they feel like a very severe pain. When you palpate, they have pain. Otherwise, not. While in MI, whether you palpate or not palpate, there is a pain. In epigastric region, whether you palpate or not palpate, they have a pain. That is MI, right? But tenderness, when you press on the epigastric region and patient has a tremendous pain, it is why? Because you are pressing the pancreas. When you are pressing the pancreas, they gets in, right, they probably worsen the inflammation, or there is a irritation of the nerve, and they feel a pain which is not there in the myocardial infarction. So these are the point, very high yield point. Comparison is very, very important. So now let's go to our stem, right? So I don't think so this is a pancreatitis. If somebody is convinced with pancreatitis, they can discuss bit more on this question, that sir, this looks like more pancreatitis. So this all history can be there, na? Every alcoholic is not pancreatic patient, right? And 1 day history of upper abdominal pain. So this is not there, right? 1 day history. What else? What do you think of this diagnosis? This is very important questions. I think there are lots of point and concept will clear. So pulmonary embolism is less
Restenosis,
likely.
Sir,
What is
Pancreatitis
it?
is less likely.
Mesenteric ischemia, sir.
Let's
sir,
discuss
3 days
mesenteric
back,
ischemia. Yes, yes.
so 3 days back, patient had stent placement and was irregular on medications. So possibility of formation of clot around the stent, resulting
Excellent.
in
Excellent.
another ischemia.
Clot or ischemia or rethrombosis or stenosis, isn't it?
Yes, yes.
Excellent. We are getting closer to the answer. Somebody told me mesenteric ischemia, right? So mesenteric ischemia, do you think there is a pain in upper abdomen in mesenteric ischemia? Number one. Number two, patient has stopped all medication and developed something again bad. So just get to the questions. This is the most likely cause of this. Now see elderly male, right? So elderly male, risk factor. Diabetes, again a risk factor for cardiac or coronary artery, hypertension, diabetes, obesity, smoking, family history, right? These are the main things. So now see once again properly, 76 years old woman brought to the ER by her son with 1 day history of upper abdominal pain, nausea, vomiting. Now she has a significant history of inferior wall MI. There is no doubt. They had given the diagnosis. No, they diagnosed. She diagnosed. So she is not suspected. She is a confirmed diagnosed case, right? And treated successfully treated with the coronary stent. So some stent was placed in the right coronary artery, which is supplied to the inferior and posterior wall of the heart, right? She lives alone. She lives alone, right? Clear cut history. Why? Because her husband died 2 years ago, so she probably lives alone, right? She has a significant history of type 2 diabetes mellitus and recently diagnosed Alzheimer disease, right? She stopped medication. Stent is a foreign body. Considered stent is a foreign body. So whenever there is a foreign body, there is a high chance of infection. Any foreign body, whether you put a nail, you put a stent, you put any things, right? Any foreign body can lead to infection. Number second is a bleeding. Number three is a restenosis or rejections in a transplant unit. These are the common complications in general, irrespective of anything. So stent is a foreign body. What she does, aspirin, clopidogrel, atosuvastatin, metoprolol, this all medications she started, right? But she trouble remembering to take medication regularly. So she is, I mean, skipping the medication. This history is little to confuse you. She drinks 2 to 3 wine daily, right? She is alert with person, but not to time. Her temperature is 37 normal. Vital is reasonably normal. So in any case, now onwards, any case, recently coronary stenting done, coronary artery stenting done, and patient stop the medicine with the history of risk factor, especially in elderly, there is a chances of a restenosis. And when there is a restenosis, again they may present with the epigastric pain or upper abdominal pain. They may present with the nausea and vomiting, right? and the patient may probably develop the dyspnea, right? So this is the likely mechanism, likely, most likely, rather I can say most likely mechanism of development of this, right? So whatever the other differential diagnosis we are thinking probably not closely matched to this, right? So now what do you think, doing what makes the diagnosis or restenosis if you want to, so which of the following is most likely to establish the diagnosis? What do you think? Measurement of lipase activity.
B, sir.
So,
Serial
right. So,
measurement of serum
Drop,
right.
troponin.
sir.
So not right. So not lipase, not amylase, because we are not thinking of acute pancreatitis, right? CT angiography of abdomen, we are also not thinking right now. Echocardiogram will help, but not echocardiogram will not help about the MI or not MI, right? You need to confirm restenosis or reinfarctions or remyocardial infarctions, right? So this is second, not the first test to do. CT pulmonary angiogram, we are not thinking because we are not thinking this, right? Esophago gastroduodenoscopy, we are not thinking any malignancy or GI things or peptic uh, in context to the history. So closest answer would be serial measurement of troponin concentration. Now, can anyone tell me why troponin, why not CKMB, or CKMB is also important along with the this? So, what is the difference between CKMB and troponin?
The timing of the raise of the enzymes. CKMB can show previous MI also, no, sir.
Wonderful. So, let me drop T or I and CKMB. First question. First question. This is all high yield or whatever duration. So, what duration it will remain in the plasma? What duration it will remain in the plasma? Simple and sober. First question.
So
Drop
10
So,
to
say
by
for
14 days. Drop by drop T.
10 to 10 to 14 days. So, just to make your job easy, I remember in this way 1 to 2 weeks, and this would be 1 to 2 days. Now, your life is easy. This is 1 to 2 week. This is 1 to 2 days. Now, easy? Yes or no? Is it easy?
Yes, sir.
Wonderful. So this is the time frame we should know. So what happens when patient comes to you with the chest pain? He develop the acute inferior wall MI, right? This enzymes will increase, right? Troponin will increase, CKMB increase, right? So they gets right. They start usual, and this usually take 4 to 6 hours to start or to present in the plasma. So 10 o'clock patient has a chest pain and 10 o'clock and 15 minutes he comes to emergency. Probably in 15 minutes, drop I may be negative, maybe negative. Because once what is troponin I basically? So this is a muscle of the heart. This is a heart and this is a myocardium. This is the muscle of the heart. And in muscle of the heart, myocardium, there is a enzyme trop I and trop T. This is cardiac specific. It is not present in the other muscle, and that is why it is the most sensitive. So, if I can ask you, which is the most sensitive marker for myocardial infarction, right? Then it is a myoglobulin, troponin T, then CKMB. The answer is a troponin T or I. Myoglobulin is present in all muscle. So if it is a skeletal muscle injury, if it is a hamstring injury, it is a myositis, it will increase. But trop T and trop I. So once this, because of left coronary artery is blocked, 100% thrombosis, then this muscle will get die. So gradually more muscle die, more troponin will get elevated. So gradually 15 minutes, 1 hour, 2 hour, 3 hour, 4 hour, it will get peak into the plasma which is detectable, so it will go right. So this is say for example normal, then the 1 hour, 2 hour, 3 hour peak, they remain 4 hours, it start 12 hours they peak, and then they gradually going down, but it takes up to 2 weeks to become a normal. This is 4 hours, say for example. So up to 4 hours to 2 weeks, they remain in the plasma. 2 weeks, right? While they get started again in 4 hours, 12 hours they are peak, and 1 to 2 days. So here 4 hours it starts get elevated. In 2 days it is gone absolutely from the plasma. So if you measure day 3, CKMB post MI, it could be normal. Is that clear to everyone? Yes or no? At least tell me yes or no.
Yes,
Yes,
sir.
sir.
Yes or no? Wonderful. So
Yes, sir.
now
Yes, sir.
we wonderful. So now when you want to know recurrence or restenosis or reinfarction, right? If somebody patient present within 14 days with the chest pain, how did you get to know which would be the best test? If you are thinking of restenosis within 2 weeks, which test is better, troponin T or CKMB?
CKMBs.
Absolutely CKMB. Why? Because this remain in the plasma for up to 2 weeks. So how did you get to know until and unless there is a extremely so here the peak hours say for here the troponin level is 10. Then here 9, 8, 7, 6, but it is elevated. It becomes normal at 2 weeks. So if it is get elevated, you confuse. But here after 2 days, if patient has a new chest pain, there are two ways by which you know that is a reinfarction and restenosis. One is a enzyme level, so enzyme CKMB after 2 days, CKMB, and second is ECG. There is a new changes of ECG which were not there earlier present on the ECG, right, along with the history of chest pain. So chest pain, it could be restenosis in both the way, but how do you differentiate? If it is in 14 days, within 14 days, better you go over CKMB, you check ECG for both the cases, right? So you get to know. So fresh or new changes of ECG plus again elevated enzyme. So say for example, normal is less than 1. Here peak 10. And here again it becomes less than 1 after 2 days. Now on fourth or fifth day again it becomes 10. That means it is elevated, means something wrong. Again myocardial has injury. Again there is an infarction, so it gets elevated. So reinfarction can be right. So infarction you can do either of the test, but more this troponin T and I are more sensitive and specific, right? So do troponin T and I. But if you are thinking of restenosis, then you can do. But if it is not there in the option, anyway you can select the troponin. If not in the option, likewise here, there is not in the options, right? So here the serial measurement of troponin. Why serial measurement? Because I told you, right? 0 hour, 1 hour, 2 hour, 3 hour, 4 hour, and 48 hours. Up to that, up to 2 days, top I would be there in the plasma. So 0 hour may be normal. Here little elevated. So after 4 hours, it is completely clear cut. I have seen many patient. Any patient comes to you in the emergency room, chest pain for 12 hours. Say for example, chest pain for 12 hours. Patient is telling you, I have morning 7 o'clock chest pain started and patient comes to you in 7 p.m. in the evening, and you just do the ECG. If you do the ECG is normal. Again, you are not happy with that. You did the troponin T and I. This is normal. This patient is very less likely that this patient has a acute MI or coronary syndrome. Whatever event would be there within 12 hours, it is clear. But what happens? Say, for example, this patient 7 o'clock come, right, chest pain, 12 o'clock comes to my OPD after 5 hours. Still the ECG and enzymes are normal. It should get elevated by 4 hours, but end of the 5 hours it is still normal. But if I feel clinically strong suspicious that this is classical MI, keep under observation for any patients for 12 hours. Any patients 12 hours you keep in your OPD in observation daycare and try to check serial ECG and serial enzyme and ECG. You do every 1 to 2 hourly do ECG, every 1 to 2 hourly do. After 12 hours, if both normal, discharge the patient at home. There is no MI. But you cannot ignore few patients may die if you are not vigilant, because they comes to you at 4 5 hours and they you feel that, oh, this is normal, you go home, nothing, blah blah blah. But they may probably end up with this in 12 hours. So any patients in doubt when ECG and enzymes are normal, but there is a high suspicious of acute coronary syndrome or artery disease, you must keep them under observation for 12 hours and do the serial ECG. So that is what the crux of the talk. Is that clear to everyone? Yes or no?
Sir, but if it is a new plot, then and if CKMB is in the option, then which one?
Then
How do we
CKMB
know
is
that
in the
it's
so it's a decide in the time frame, na? 3 days ago. So you better go with the CKMB. Simple. If both are in option,
Okay.
troponin
Okay,
plus
okay.
CKMB, reinfarction, if you are thinking, give this.
Okay, okay,
And
okay.
and sir, restenosis can happen so fast, like in the span of 3 days
Absolute,
after.
absolutely
Okay,
possible, possible,
okay,
possible, possible, possible.
okay.
Because he is a high risk patient, already done recently. Stop the
Mm-hmm,
medicine. That is why aspirin needs to be continued almost lifelong. And
mm-hmm.
clopidogrel we usually give on the risk factor. We means I mean cardiologist usually give for 1 to 2 year, and then depends on the condition of the patient. Double anticoagulant is a problem in the elderly people because they also have a risk of bleeding, especially the GI bleeding or intracranial hemorrhage or others. So aspirin and clopidogrel is a dual antiplatelet drug. We'll discuss sometime in hematology, but it's a dual antiplatelet. Both are acting on the platelets. It's a platelet factor inhibitor, right? So aspirin and clopidogrel. It's not warfarin. Warfarin is a act on the factor, right? In the clotting cascade, they act on the platelet. So we'll discuss factor versus platelet bleeding sometime. So that's it. This is what the thing is. So cardiac troponin is one of the most sensitive biomarker of myocardial infarction. It can be used to detect reinfarction because it can 6 to 14 days for troponin, and that we discuss all, right? So that's all. This is nothing new. I mean, we discuss everything and we excluded other things as well, right?
Sir,
Somebody
because of
was tell 1 second, I'll finish, then you ask. CT pulmonary angiogram, somebody asked P. So discussion of this thing is CT pulmonary angiogram is most definitive diagnosis of pulmonary embolism, which can manifest with acute dyspnea. Although an asymptomatic presentation is possible, often features are such as pruritic chest pain, cough, hemoptysis, tachypnea. These all are the symptoms of pulmonary embolism, which is not there. Unilateral pain, leg swelling, DVT are commonly seen, which is not there. Moreover, P does not explain the patient's abdominal pain and nausea, which is also not there in PE. So this is not favoring P. Somebody, just for your understanding the concept. Another people told CT angiogram of abdomen. So CT angiogram of abdomen is diagnostic for acute mesenteric ischemia, which can manifest as a nausea and abdominal pain. That is disappropriate to physical findings. In addition, recent myocardial infarction is a risk factor for acute MI. However, bloody diarrhea, periumbilical, and periumbilical rather than upper abdominal pain. So this is again a differentiating point, not for the mesenteric ischemia. So it's important. Somebody told mesenteric ischemia, excellent, good differential. But what happens in mesenteric ischemia? Usually, when there is a mesentery is ischemic, there is a blood PR. This is most important, or bloody diarrhea, and pain is not in the this upper abdomen. This is only periumbilical pain are commonly. And finally, AMI does not explain this patient's this dyspnea. Anyway, yes, somebody was asking me questions.
and regarding the peptic ulcer, sir, I could see the explanation over there.
Yeah, so peptic ulcer is esophagoduodenoscopy is the most accurate test to confirm peptic ulcer disease, which can manifest with upper abdominal pain and nausea. Moreover, heavy alcohol and dual antiplatelet increases the risk of peptic ulcer disease complications such as bleeding ulcer, which may manifest with dyspnea due to anemia. However, clinical features suggest of dyspepsia pain related to the food intake, hematemesis, and melena, right, in patient with bleeding are also expected. Finally, this patient has most likely not adhere to her antiplatelet regimen, right? So this is more of likely diagnosis of troponin. So in case of any case in general, acute myocardial infarction, stent placement, something goes wrong within 1 week of time, think of brain stenosis. That is a take home message for this. Try to look out the other things as well, but in general, look into this, right? So there are a lot of questions with acute MI. We'll discuss sometime in cardiology as well. So second little important questions. 15-year-old male. Today all questions are little tricky, mind brainstorming, so not one liner. 15 years old male undergoing appendectomy, developing increased temperature, acidosis, and muscle rigidity 20 minutes after administration of succinylcholine. How do you manage this patient? Pause the surgery because patient right undergoing appendectomy develop increasing temperature. So they open up the tummy, laparoscopy or open, just remove the appendix. Now, just within 20 minutes of giving succinylcholine, right, patient develop all these things: temperature increase, acidosis, muscle rigidity in 20 minutes. Pause surgery and discontinuing the trigger agent. Administer the IV dantrolene. Cool the patient with core temperature of more than 90. If it is 39, patient has a fever, they have mentioned. So do cooling. All of the above is correct measure. What is the diagnosis and treatment? So you think over it. What went wrong in the surgery? After giving the succinylcholine, patient developed this muscle rigidity, temperature, and acidosis. Something went wrong in the surgery, or anesthesia, or something went wrong. So what do you think? What went wrong? What are the differential diagnosis? Without diagnosis, will not jump on any treatment or anything. Diagnosis or differential diagnosis? I will tell you three differential diagnosis: malignant hyperthermia, neuroleptic malignant syndrome, serotonin syndrome. These are the three differential diagnoses from my side. Now you justify what it could be and how this differ from this and this differ from this.
Uh, this is Malik. Malik. So can I?
Yeah. Please, please, please. Open for all doctors. It's a learning platform.
So this is malignant
Sorry, what
hyperthermia.
first decide what
Probably
is the diagnosis?
malignant hyperthermia.
Malignant hyperthermia. Okay, fine. Let's discuss malignant hyperthermia. Can you define what is a malignant hyperthermia definition in general? Whatever is in your mind about malignant hyperthermia, define.
So while administering, it's basically here the malignant hyperthermia occurs after administration of the succinylcholine.
Fine. No, but how
So
you
here the
define
patient
hyper?
has fever and has
Okay,
muscle rigidity
so
as well.
name itself suggests malignant hyperthermia means there must be
Mm,
a high grade fever and temperature to the patient, right? Fair enough.
high grade fever.
Okay,
Yeah.
fair enough.
Yes.
What
Yes.
could
Yes.
be the cause here?
Yes.
What could be the cause of the malignant hyperthermia here?
Sir, I'm not sure,
Here
but
the
is there
triggering
any
agent
genetic
is
problem?
succinylcholine.
Genetic problem, somebody told me. So what genetic problem you think that this patient have? What genetic problem? You can name some genetic problem.
আমি বাবা ক্লাস করি
Sorry?
উফ
Sir, here actually the triggering agent is succinylcholine.
Excellent. Succinylcholine. Because it's something went wrong. Na? After administration of succinylcholine, I'm just
Exactly.
I'm muting all. Huh? You can unmute your mic because there are a lot of background baby's noise. Sorry. So you can unmute. So succinylcholine, that could be caused. What is the time frame after giving the succinylcholine? In what time frame usually malignant hyperthermia will develop? 6
I think
hours,
it's
12 hours,
1 to 2.
24 hours.
It's immediately after giving the drug. 1 to 2
So,
hours, I think.
so
I'm
say
not
for
really sure
example,
time.
10 o'clock surgery started and 10:20. After 20 minutes, he developed the things, right? Malignant hyperthermia, he developed, right? In 20 minutes. And they are saying in 20 minutes, right? So what do you think?
Hmm.
Up to what time frame the malignant hyperthermia will develop? Up to 1 hour, 1 hour of
1
anesthesia,
to 2
up to
hours.
2 hours, 1 to 2 hours, right?
Yes. Yes, sir.
1 to 2 hours. So you mean to say after 2 hours, malignant hyperthermia will not develop, right? In
No,
general,
but we
don't take
have
it
to
as
give the
advice. I'm just
treatment.
trying to understand.
No, no, no. We have to give the treatment, and we have to.
Fair enough.
Uh,
Fair enough.
First
So
of all,
now
the
we come to
answer
the
for this
treatment
is
as well.
D. Yes,
Okay. So
yes, yes.
treatment, what will you treat in the patients of malignant hyperthermia?
So first, and as the option A says, we have to discontinue the triggering agent,
Okay. So we'll discontinue the triggering agent. Okay. What else you want to do?
and definitely cooling the patient.
cooling the patient because the patient has hyperthermia. Okay, what else you want to do?
And dantrolene also is the drug of choice for
Dantrolene is a
malignant
drug of
hyperthermia.
choice. Wonderful. Where
Yes,
does it act? Where does it act? Which group of this drug? Which group of the drug?
it's a
And where does
muscle
it act?
relaxant. Muscle relaxant.
Muscle relaxant. Muscle relaxant. Okay, fair enough. Fine. So now what else you want to do? You pause the surgery, you give dantrolene, you cool the temperature. Means your answer, that means all of the above is correct, right?
Yes, yes.
Wonderful. Why it is not a neuromalignant syndrome? What is neuroleptic malignant syndrome?
Neuroleptic malignant syndrome, the time frame is also different, and it usually happens after giving antipsychotic drugs.
Excellent. Wonderful. Very wonderful. This is what I want to hear. Neuroleptic malignant syndrome. Neuroleptic means neuroleptic drug, right? Neuroleptic drug. This succinyl is not a neuroleptic drug. Fair enough. And what is serotonin syndrome? I'll give you the differentiation, crystal clear differentiation, give you in a 1 minute. Serotonin syndrome where? When you label that this patient has a serotonin syndrome, because we
Uh,
always confuse
the
every time with this three differential. That is why I took this question, and
the
we try
drug
to avoid
is
it.
a causative drug is also different. Serotogenic magic
Yeah.
drugs,
So
serotonin.
serotogenic is the drug. Serotogenic, where the serotogenic
Yes,
drugs are there, right? So answer
mm,
for this is a D. Now let's
yes,
excellent. You can take a picture of this chart, or you can remember, or we will upload this anyway on the YouTube, so you can anytime you will get, right. So now see the simple malignant hyperthermia, neuroleptic malignant syndrome, that is NMS, neuroleptic malignant syndrome. This is serotonin syndrome, and this is malignant hyperthermia. So first and foremost important basic things, inhalation of the anesthetic, especially succinylcholine, which is there in our scenario. Tick. This is what is the cause, right? Agent in, right? What are the causative agents? So here neuroleptic malignant syndrome. So there is a neuroleptic antipsychotic agent, drugs, right? And here serotogenic drug, right? Drug which is contains the serotonin. Because of that, there is a serotonin syndrome. Excess of the serotonin can cause syndrome. There is a serotonin syndrome. Onset is extremely important. Here minutes to hours, doctor. Minutes to hours. Here days to weeks, because antipsychotic drug goes into the body for 1 week, 2 week, 3 week, 4 week, then develop the neuroleptic malignant syndrome. This is in the absolutely weeks, never ever in minutes or hours, never in a minutes. So today morning you took antipsychotic drug, dopamine antagonist, and evening you develop, never ever develop. It takes days, maybe 5 days, 10 days, 15 days, 2 weeks, right? So it is all in the weeks. After starting the medication, 4 weeks, 5 weeks, 6 weeks, they develop. This is minutes. In our scenario, 20 minutes. Is that clear? Yes or no? At least tell me yes or no, right? And this
yes,
is
sir.
also in hours. This is also in, not in the minutes, usually it's in hours. So this is clear cut differentiate. So you can say this is minute, this is in hours, and this is in the weeks, days to weeks. So this is excellent clear cut symptoms. Number three, mental status. Mental status, here they are because of hypothermia, agitated. They are here, they are mute or catatonic, and here confused and agitated. This is little difficult to differentiate in all this, but this is the extremely important. What agent causes will make you the diagnosis in your exam. Time of onset, here the muscle symptoms again. Here bradykinesia, brady slow, everything is slow. Hyporeflexia, and here the hyperreflexia. Remember, simple thing, not complicated thing. And extremely important is the vitals. Severe hyperthermia, 104.5 temperature could be there. Here mild hyperthermia, never very severe hyperthermia, and here almost no hyperthermia. It is autonomic instability because of excessive serotonin. It's okay. Here the treatment part of this, right? Cooling, yes, it is in the options. Muscle relaxant, yes, in the option. Or dantrolene, yes, in the options. So this is a treatment of choice, right? What is the treatment of choice? Here the temperature is also there, na? So here the same cooling Why? Because temperature is here. Here temperature is, so cooling is both the things. Here also muscles are, right? There is a catatonic and rigidity, is a rigidity, so you give the muscle relaxation, but the difference is that it acts on the different way. So bromocriptine is a drug of choice. Fix in your head, they will ask you in the exam, drug of choice for neuroleptic malignant syndrome, bromocriptine, drug of choice for malignant hyperthermia, dantrolene, right? And third, serotonin syndrome, again there is a temperature, so cooling should be there, muscle rigidity, relaxation should be there, but the again the reversal agent is a cyproheptidine or chlorpromazine. Cyproheptidine or chlorpromazine. These are the drug of choice. You must remember. So this is all the treatment options. So what you need to know, concluding my talk, what is the agent? So first, any exam, whenever you are confused between three, look at the what causes, right? If it is an antipsychotic, it is neuromalignant, it is serotogenic, it is serotonin. If it is anesthetic agent, inhalation anesthetic agent, especially succinyl, right? Then it is hyper. Second most important differentiating is a minute, hours, weeks, and hours, right? So in what time frame they will completely clear cut give you. So if you go back to the scenario, nothing is confusing in the scenario. Now go back to the scenario, right? It's absolutely crystal clear now, right? What they had given in the scenario is absolutely crystal clear, right? They are undergoing surgery, they develop the hyperthermia, acidosis, muscle rigidity within 20 minutes, succinyl choline, malignant hyperthermia. Drug of choice, dantrolene. That's it. So all everything will they will give you in this exam. They will give you all high yield point. Our job is to just open up our mind, look into the questions well, read it well. Don't need to jump on the answer before reading the questions well. That is a trouble point. So we don't need any trouble in the exam. Is that clear to everyone? Yes or no? Yes
Yes,
or
sir.
no?
Yes, sir.
Yes, sir.
Yes.
So this is, I think, very nice chart. It is not in the book. Got it from another journal to differentiate and make it easy for you guys. So it's a very crystal clear chart. Let's get to the third boring questions. Upper motor and lower motor. People are always confused, and that is the question. Sorry for making this little more tricky mock test, but it's eye opening for a lot of people. You must know where you are standing. Upper motor neuron lesions are characterized by all of the following except means one is not there. Except means one is not there. All are upper motor neuron, one is not there, right? Or all are there. You apply your mind. Babinski sign positive, increased stretch reflex or hyperreflexia, increased muscle tone or hypertonia. Stroke is one of the etiology of our upper motor neuron lesion. All of the above are the upper motor neuron. Take your time, take your time. And anyone who starts interacting, I want to know what is the difference between upper motor neuron and lower motor neuron. Few
Upper motor
questions with
neuron is,
one second,
uh,
doctor, one second,
okay.
one second, one second. I'm coming to you. For learning for everyone, upper motor neuron, lower motor neuron lesion. First, where is the site of the problem or lesion is where, in which part of the central nervous system? What happens to the reflex? What happens to the tone? Where is the lesion, right? What is the Babinski and what is the treatment? Now, anyone can start. If you understand this, you never ever forget this in your lifetime. Believe me. Now onwards, upper motor, lower motor, never any confusion in next 5 minutes. Yes, go ahead.
Sir, upper
Anyone
motor
else?
neuron is from the cortex to anterior hornsel of the spinal cord.
Wonderful, wonderful, wonderful. Okay, so let me
And
draw. This is a brain. This is a spinal cord. Just probably my drawing is not very fancy, but just make you understand. And this nerve endings are removed from here. This is nerve ending, right? This is a spinal cord and this is a vertebrae. This is muscle, skeletal muscle. Now tell me, this is completely central and peripheral nervous system I draw in general. So where is the problem in the upper motor neuron? Listen.
From the cerebral cortex to
Cortex.
the anterior horn of the spinal cord.
Okay, great. So here upper motor, let upper, the name itself suggests upper. So maybe a brain. So here cerebrum, cerebellum means chota magaj, behind occipital, cerebellum, cerebrum, cerebellum, and spinal cord. Is that clear? Yes or no?
Yes.
Right?
Yes.
Yes.
This is cerebellum. If I can draw a little bit, just to. So cerebrum, cerebellum, spinal cord. This is upper motor neuron. And from spinal cord, now lower motor
Neuromuscular.
anterior horn cell. So this is picture. So from anterior horn cell, it goes to the now. This is now ending. This is muscle. It supply.
Neurom
This is neuromuscular junction. This is muscle. This is anterior horn. So from anterior horn, neuromuscular junction and muscle. This is in a lower motor. Is that clear? I'll show you the
Yes.
picture.
Yes, sir.
Fine. So something wrong in the cerebrum, cerebellum, or spinal cord. There is a upper motor neuron lesion. From upper, it goes to lower. These are in the lower. This is in the upper. So stroke is one of the etiology in upper motor neuron. Yes, because if you have a cerebral ischemia, stroke is one of the reason, isn't it? Yes or no? Right?
Yes, sir.
Reflex when there is the upper, every up, this upper means the word is upper motor neuron. So remember up, upper means up. So tone is up. The easiest way, tone is up means hypertonia, hypertonia. Reflex is up means hyperreflexia, hyperreflexia, hypertonia. Toe of your things is up. Toe of your lower limb is up. This is your foot, up, up. Babinski positive, it's up. So everything is up in the upper motor neuron paralysis or upper motor neuron lesion, right? This is the most important picture. I got it for you once again just to make yourself a bit more clear. So this is a brain, right? This is a cerebellum. This is cerebrum. So in general, it is completely brain. So complete brain, primary motor cortex, that is a cerebrum. This is cerebellum. So in general, it is a brain. This is spinal cord. This spinal cord. So from brain, this green line, if you can little appreciate my green line, this ends here, this ends here. This is upper motor neuron. Green is upper motor neuron and blue is a lower motor. So here from lower start. So from spinal cord, now this green stops here and blue will start. So anterior horn, this is anterior horn, right? This is a peripheral nerve, neuromuscular junction, and this is a muscle fiber, right? So this is lower motor neuron. So muscle is in lower motor neuron, right? So any injury is lower motor neuron paralysis, right? You don't need to mug up. You need to just understand where is the problem, right? So this is the understanding of upper versus lower motor neuron. Let's discuss head to head how you differentiate upper from the lower. So let's get clear. So as I told you, upper motor neuron lesion, site of the lesion, cerebrum, cerebellum, brain, and spinal cord. Is that clear? Yes or no? At least tell me yes or no. At least tell me
Yes.
yes or no.
Yes,
Yes,
sir.
doctor.
Lower motor neuron, anterior horn, nerves, neuromuscular junction, muscle. I cleared it to you, right? Muscle weakness, you can develop quadriplegia because of brain. Something wrong in the brain. Anterior cerebral, middle cerebral, posterior cerebral, stroke, ischemia, hemorrhage, blah, blah, blah. Long list. Anything happen wrong, you get the upper motor neuron. Quadriplegia means all four limbs gone, two upper, two lower. Hemiplegia, either right half or left half. Hemiplegia. Diplegia, both upper, both lower limb. And triplegia, very rare, three limbs gets affected, right? Here, lower motor neuron Proximal and distal. Proximal is because of myopathy, and distal neuropathy, diabetic neuropathy is a lower motor, diabetic neuropathy. Nerves gets damaged, peripheral nerves gets damaged. You cannot have sensation, you cannot have the things, feeling, right? So it's a lower motor neuron. Muscle tone, hyper rigidity, spastic or hypertonia. You can say simply hypertonia. Means here all up, hypertonia, here all down. Lower means low, lower means low, upper means up, means everything is high, everything is low. So either tone is high, hypertonia, tone is low, hypotonia, right? Another is reflex, upper, hyper, all up, hypo, less, lower, less, low tone, low reflex, hypotonia, hyporeflexia, hypotonia, hyporeflexia, all low, lower motor neuron paralysis. Sensory cortical sensation. I'm giving you high yield point. Here the peripheral sensation. Electromyogram. Electromyogram means if you do the EMG study or NCV, now conduction velocity or study, normal now conduction. Why? Because nothing wrong in the peripheral now. So now conduction study or now conduction study normal. Here slow now conduction. Why? Because now neuromuscular junctions, muscle, this now anti-horn cell, right? So if now is that problem, if you do now conduction study, it is slow. Why? Because there is a problem in the now, in the lower motor. It is normal. Now is normal peripheral. That is why now conduction in upper is normal, right? So this is all head-to-head differentiating point for the upper versus lower motor neuron paralysis. Is that clear to everyone? Yes or no? At least tell me yes or no.
Yes, doctor.
Yes, sir.
Yes, sir.
Yes, sir.
Yes,
Wonderful,
sir.
wonderful, wonderful. We need to understand. We don't need to mug up because we are mugging up this upper neuron. Even I was struggling in my physiology day because I did not have concept. Now we are mugging up. Where is upper, what is no lower? So this is concept, right? So now we need to know. And this is again a chart. I got it from the Emboss, a different book and journal. It is by and large mentioning the same upper motor neuron versus lower motor neuron lesion. So lesion in the brain, cerebrum, cerebellum, and spinal cord. Here, I told you same thing. Muscle here, right? Hypertonia, hyperreflexia, it is there, right? Babinski is up, upper motor neuron up, lower motor neuron low or down. So Babinski sign, I will show you the Babinski signs as well, right? And common etiology, you must know common etiology, right? So what is the common etiology? So here multiple sclerosis. Why multiple sclerosis? Because problem in the gray matter in the brain. So brain is upper motor neuron, right? So multiple sclerosis. Tumor is in the brain, upper motor. Stroke because of anteamidal posterior cerebral ischemia or hemorrhage. Stroke, brain, upper motor neuron. B12 deficiency affects the neuron. Amyotrophic lateral sclerosis is only condition in which you get upper and motor neuron. So this is exam question in exam question. Amyotrophic lateral sclerosis, which kind of lesions in upper or lower? Answer is both upper plus lower motor neuron. Only example, there is a problem in the brain as well as problem in the nerves. So amyotrophic lateral sclerosis is the example of both upper plus lower. Peripheral neuropathies, yes. Diabetes mellitus, lower motor neuron. Poliomyelitis, yes. It is a nerves, peripheral nerves or polio, right? So this is an example of a lower motor neuron paralysis or lesion, sorry, right? So that is how you need to differentiate, and you need to, this is again a very important pictures. I love pictures, so I include lots of picture in my presentation. So that's it. This is what again the same schematic presentation, upper motor versus no low neuron lesion. So here mnemonic in lower motor neuron lesion, muscle mass, muscle tone, muscle power, and muscle reflex are low. Why low? Because it is a lower motor neuron. Upper motor all up. Babinski up. This is upper motor neuron. That's all for upper and lower motor neuron, I think. And this is last but not the least, excellent picture again before ending up the upper lower motor. This is one of the most take a picture. Upper, more spasticity, more tone hypertonia, hyperreflexia. Toe up, positive Babinski. This is positive Babinski. Toe is up. Up means upper motor. Low, this is low, going down. Lower motor. Low, down, lower motor neuron. Is that clear to everyone? Yes or no?
Yes, sir.
Yes, sir.
Yes,
Any
Yes, sir.
any any doubt? Answer these questions now. What is the answer? Everyone post the answer.
E.
E, sir.
Sorry. Yes, E. E is the answer. Babinski is up. Positive means up, right? Babinski positive means what? It is up, right? So this is toe is up. Toe is up. If toe is down, it is a lower motor. So this is up. Toe up or positive. Upper or hyper. Upper means all up. Hyperreflexia, hypertonia. Upper stroke, cerebral ischemia is in the brain. Lesion is in the brain. Upper motor. All of the above are seen in upper motor. Is that clear? Yes or no?
Yes, sir. Sir,
Yes,
one
sir.
doubt.
One.
Clear.
Sorry.
Sir, there one doubt. Can I ask?
Yes. Yes, please.
Sir, the muscle power decreases, no, sir? Because in the stroke patients, we see that the muscle power normally that decreases. Although they are hyperreflexia and hypertonia, but the power uh, seems to be less.
Yes. So there. So again, this chart atrophy is absent and fasciculations are absent. And here the so reduced power in the muscle group. See, it is clear cut. Whatever you told, it is there already, right? But I'll
Yes,
just
sir.
give you the high yield. So here, if you read this characteristic, right? Tone up. So it is hypertonia, right? Tone is up. Hyperreflexia. Just reduce power in the muscle group. So whatever the muscle groups are there, the power is reduced.
Okay.
Power is reduced because of stroke, no? So power is reduced. But if you see the tone, it's increase. If you see the reflex, it's increase. Right?
Yes. And
You're
in
right.
stroke patients, we give Foley's because of this detrusor hyperreflexia only, sir.
Exactly. So see,
Okay.
but they are little less high yield. Just I want to make you understand what exactly upper and motor neuron. There are long list, but clinical point of view, if you remember this much, it's well and good. Fair
Thank you,
enough.
sir.
Shall we move ahead? Excellent. All brainstorming questions today. Huh? Sorry for little long, lengthy questions, but important. 40 years old woman comes to the physician because of small lump in the right side of her neck that she noticed while putting lotion on 1 week ago. So while young lady putting a lotion on the neck, she found to have some neck notice. Right, there is a lump, small lump on her right side of the neck. She has not had any weight changes, palpitation, or altered bowel habit. There is no family history of serious illness. Menses occurs at regular interval. Regular 30 days interval lasts for 4 days. She appears well. Her temperature is 37 or 98.6. Pulse is 88. Pressure is 116 over 74. Examination shows a small nodule on the right side of the neck that moves with the swallowing. There is no lymphadenopathy. The lungs are clear to auscultation. The remainder of the examination shows no abnormalities. Ultrasound of the neck showed on 0.9 centimeter right lobe thyroid mass with microcalcification and irregular margins. Which of the following is the most appropriate next step in the diagnosis? Fine needle aspiration cytology, fine needle aspiration, biopsy of the swelling, open biopsy, thyroid scintigraphy, thyroid stimulating hormone serum concentration, CT scan of the neck. As usual, I have three questions. What is the diagnosis? How you investigate? And what is the treatment? So first make little diagnosis or differential diagnosis. You think over it. What is wrong with this patient? We'll discuss. Nothing urgent.
They're either toxic or non-toxic processes.
So first of all, diagnosis, where is the problem? Where is the problem in this patient? Or what is the diagnosis?
It's a thyroid gland abnormality for sure, sir.
Okay, so 1 minute, I'll write down, doctor. Thyroid, this is basically thyroid problem in short,
Yes.
right?
Yes.
Fine. Now, can anyone tell me whether it is hyperthyroid or hypothyroid or euthyroid anyway, or normal thyroid, euthyroid?
Looks like euthyroid, sir, because there
Yeah.
is no weight change or palpitations. If there was hyperthyroid, she would have loss of weight and palpitations for sure.
Okay. So hyperthyroid is what? Cold intolerance or hot intolerance?
Heat intolerance.
Hot
Heat
intolerance.
Hot intolerance. Just for other people's also, I'm just giving, don't take it otherwise. Hot intolerance. Here, cold intolerance. What happens to pulse rate? Tachycardia or bradycardia in hyper?
Tachycardia.
Tachycardia, sir.
Tachycardia. Here, bradycardia. Isn't it? Yes or no?
Yes.
What about weight? Weight gain or weight loss?
Weight
Weight
loss.
loss.
Weight loss in hyper. Weight gain in hypo, right? Because the BMR, basal metabolic rate is low because of low thyroid. It are high, right? Basal metabolic rate. So they have a weight loss. What about the menstruation in the hyper and hypo?
Hyper, it becomes
Scanty.
oligo
Scan.
Oligo or scanty.
oligo.
And here
Yes.
hyper
Menorrhagia.
Menorrhagia.
means increased menses shortly, right? Or high menses or high flow or frequent. So these are the point favoring the hypo and hyperthyroidism in general. When patient comes to you, they mention you the symptoms, right? And sometimes it is subclinical. So you probably miss the thyroid to diagnosis in your day-to-day OPD. So now what do you think? What problem this patient has thyroid problem?
Uh,
Carcinoma, sir.
no, if it
Oh,
is carcinoma, weight loss and lymphadenopathy or some lungs, something should have been positive, no,
It
sir?
moves with swallowing. So usually thyroglossal cysts move with swallowing
Sir,
I think it
or
is a
when the tongue is
thyroglossal
protruded.
cyst.
the mass is having microcalcification with irregular margins. So most
Regular.
probably it will be cancer.
Slow growing carcinoma.
Okay, so carcinoma. What are the type of thyroid carcinoma? This all are exam questions. Sorry. Thyroid carcinoma. Let me ask you a question. Which is the most commonest thyroid carcinoma? You
Papillary.
can see. So
Papillary carcinoma.
two different question. Most common papillary. Which is the worst thyroid carcinoma in terms of
Anaplastic.
prognosis?
Anaplastics.
Excellent. Anaplastic. I think you are well prepared today. Anaplastic carcinoma of thyroid is the worst carcinoma. Papillary is the most common, right? So this carcinoma or suspected carcinoma, right? So there is now see the examination. So small nodule, nodule is not big on the right side of neck, moves with swallowing, no lymphadenopathy, lungs are clear, all right. Other examinations are clear. Ultrasound shows is this microcalcification and irregular margins. So now what you want to do from this, right? As a next step, they are saying the appropriate next step. They are not saying confirmatory diagnostic test. They are not asking confirmatory diagnostic test. It's a different answer. They are saying you have this patient, you are suspecting thyroid cancer. What will you do the next? After
We'll
next,
do
I
the
will tell you what will you
TSH.
do the next.
TSH serum concentration.
Yes,
T- Okay, so TSH serum concentration. So how many of you are not agreed? Just post the answer in the chat box. Not agreed.
Sir, FNAC, fine needle aspiration band.
Okay, so would you directly go for the fine needle aspiration without doing the TSH?
No, no.
What is the guideline? What is the schematic presentation of approach to an thyroid nodule? This is basically thyroid nodule, isn't it? Yes or no? Am I right? Yes or no?
Yes, sir.
Yes,
They,
sir.
they say na small nodule. So thyroid nodule basically is thyroid nodule. Thyroid nodule can be benign. Thyroid nodule can be malignant. It is not always malignant, isn't it? Yes or no? All lump in the breast is not this breast cancer. Na? It could be a fibrocystic disease in a young patient. It could be fibroadenoma. It could be malignancy. Likewise, every node, every nodule is not malignant in the body, isn't it? Yes or no?
True, sir.
Yes, sir.
Yes.
Yes,
So
sir.
now what? So what you want to do?
TSH, sir.
Sorry, TSH. Okay, great. So that is the answer. TSH is the answer. So now I will show you the guideline. I mean, we are going absolutely through the literature, not just a verbal talk. We'll go with the guideline. So now this is the chart. Can everyone can see this chart? Yes or no? At least tell me yes or no.
Yes, sir.
Yes, sir.
Yes, yes, sir.
Wonderful, wonderful. So now let's discuss this chart. Evaluation of the thyroid nodule. So this lady has a right side neck, small thyroid nodule, right? It is given already, which shows microcalcification on USG. So they have done USG, but it's fine. So what is the approach? You should not miss this flow up to down. You cannot bypass this. So first thyroid nodule, then history, absolutely. Physical examination, absolutely. Ultrasound you can do. You cannot miss the TSH. This is the answer. Yes or no? Yes or no?
Yes, sir.
Yes, sir.
Wonderful. Now
Yes.
there are two possibility. Either TSH is low or TSH is high or normal. So here the TSH is low, TSH is high or normal. This is a sign of normal, right? Now the problem is, or when the TSH is high, say, or normal, say for example, right? What you do in case of TSH high or normal, indication of fine needle aspiration cytology. So first, that means TSH is number one things which you should not miss. On the TSH, you should triage for the biopsy, for FNSC, for blah blah blah, whatever. So indication for fine needle aspiration cytology. In indication of fine needle aspiration cytology, right? Yes, you did a fine needle aspiration and you did a cytology, and depend on cytology, you treat whatever benign versus malignant, right? And indication for needle, right? For fine needle aspiration, no, monitor with the thyroid ultrasound, right? So thyroid scan or thyroid USG you can do. This part is tricky. When the TSH is low, thyroid scintigraphy, hot nodule, and just evaluate for hyperthyroidism. Just for your knowledge, TSH is low and T3, T4 high is hyperthyroidism. So in hyperthyroidism, T3, T4 high and TSH low. This is classical. TSH is low. It is a hyperthyroidism. They usually have hot nodule on thyroid scan. They have a cold nodule here, cold nodule. So thyroid scintigraphy, if you do, there is a hot nodule or there is a cold nodule. Two possibility. If it is a cold nodule, it is suspicious of malignancy. Go for biopsy or go for scintigraphy. So what is the bad in thyroid nodule? First you do the history, physical examination, ultrasound. This is basic. Then TSH. TSH there are two ways, either low or high slash normal. If it is low, it is a hyperthyroidism. No need to do the biopsy. If it is a right, if it is a TSH is high means hypothyroidism, high chances of malignancy. They are cold nodules usually. Do the biopsy or FNSC. This is what the guidelines says. right? So you cannot directly jump on the biopsy or you cannot directly jump on the FNSE without measuring the TSH level. And on TSH level, guideline says this is how you supposed to approach on the level of TSH. Let's go little further to get you the more clarity, because many people doesn't know what is hot, what is cold nodule. I know what you don't know. So more clarity. Hot nodules is what? Cold nodule is what? We read 100 times, but we don't know the exact concept. So hot nodule, cold nodule, and there is another word, warm nodule. Warm nodule is also there, but not going much in detail. Hot nodule, also known as a autonomous or toxic nodule. How it looks like, I'll show you. Usually non-cancerous, usually non-cancerous, usually non-cancerous. And hot nodules, either TSH, as we see, is either high or normal, non-cancerous, usually non-cancerous, and can cause hyperthyroidism, obviously, right? When TSH, right, hyperthyroidism, and can be treated with radioiodine, surgery, or ethanol injection. Cold nodule, 5% risk of being cancerous. So this is, cold is more dangerous than hot. So this is more concern, right? Usually seen in a hypothyroidism, can be benign or malignant, but in 5% cases, it's malignant or cancerous. Can be asymptomatic due to their size, can be treated with radioactive, iodine, or hormone suppression, and may require surgery, thyroid lobectomy, or complete thyroidectomy. Diagnosis of any thyroid nodule, hot versus cold. Thyroid scan can identify hot or warm or cold. So how did you get to know, sir, this is hot or warm? The name of the test is thyroid scan. Thyroid scan. How it looks like, I'll show you. Then you can go for, depends on that. If it is a cold, go for this. Hot, hyperthyroidism, evaluate, right? Fine needle aspiration can collect a sample of the node of the testing, and blood test can check the thyroid hormone level. So these are the various tests. So cut short my talk, thyroid nodule, first of all history, physical examination, and USG scan, then thyroid stimulating hormone either low, high, or normal, right? Depends on low. This is looks like a hyperthyroidism, and this is looks like a hypothyroidism. This is a cold nodule. This is hot nodule. Hot nodule is usually non-cancerous. This is highly cancerous, and hot or cold can be no on thyroid scan. Is that clear to everyone? Yes or no?
Yes, sir.
Yes or
Sir,
no?
Yes.
example of
Yes, sir.
example
Now
of
see
hot
the,
nodule.
yeah, I'm coming on that point, doctor. So this is normal thyroid, right? This is thyroid gland. It is in the front of the neck. Here, thyroid gland. Behind thyroid, there are two pairs of parathyroid. So when you remove thyroid, many a times parathyroid is gone, also gone. So prothormone is gone, which increases the calcium. So patient develop hypocalcemia because you remove the parathyroid as well along with the thyroidectomy. Cold nodule. So this is cold nodule on the thyroid scan. This is warm, means more darker, and very much darker. So dark, less dark, very dark. Multiple nodular goiter, toxic nodule. They are usually hot. Hot nodule is toxic goiter. Multiple nodular goiter. Graves disease, completely in the both. It is a Graves disease, hyperthyroidism. So whole gland is uniform, and thyroiditis, inflammation of thyroid gland, that is thyroiditis. So this is general understanding for you to know. They won't ask you the picture recognition, how cold and hot, but just for your knowledge, if you see the thyroid scan, there looks like this. Somebody told about thyroid cancer. So there are four main papillary, 90%, 5 year survival. This is the best prognosis. If they ask you the exam question, which thyroid cancer has a best prognosis? Papillary. Second most is a follicular. Second most medullary, 50%, 5 year survival. And worst one, worst, poor prognosis is a anaplastic. Somebody told the answers as well. So these are the four common. There are a lot more things to discuss about this, but this is what the commonly the question asked in the exam, and it is very important for you. Thyroid is a common problem in female, especially. It's an autoimmune disease. Hypo is a Hashimoto's disease, one of the most common cause across the globe for primary hypothyroidism, where you see the high TSH and low T3, T4. That is a classical, and TPO thyroid peroxidase or antithyroid antibody is the antibody which kills the thyroid follicle and do the hypothyroidism. Treatment is a thyroid replacement. That's it. So this is what the thing is. So you need to know. So now what's the crux of the question? This is the answer. Measurement of TSH, that is thyroid stimulating hormone, serum concentration, and thyroid ultrasound should be performed in all patients with a suspected thyroid nodule. In our case, thyroid scan we did it. So what is remaining is TSH. That is the answer is TSH to determine the further management. If the TSH levels are normal or elevated, patient should undergo regular monitoring in case of more than 1 centimeter tumor size or nodule, in which in which the case FNSA would be indicated because of suspicious of under ultrasound finding mass with microcalcification and irregular margins. If TSH levels are subnormal, she should be evaluated for the hyperthyroidism with thyroid scintigraphy or thyroid scan or hot nodule or cold nodule, and then you decide what to do in terms of further management. Is that clear to everyone? Can anyone reply yes or no?
Yes, sir.
Yes, sir. Clear, sir.
So take a picture of this chart. Probably not in the books. I don't know. I got it from other journals and all. Anyway, so this is clear cut. This guideline for evaluating any thyroid nodule, right? So this is commonly comes in the exam in the thyroid nodule. So don't miss out this thyroid nodule. Long questions, but easy questions. Just bear with me 5-10 more minutes. Probably last or second last question. 22-year-old, easy question. This question is easy, so don't scared of long scenario. And just one more tip, when you don't understand anything in long scenario, my general experience, last 2-3 lines are very important. Maybe this is a vague advice, but this is what I evaluated over many years. Last 2-3 lines are very important when you, because what happens when the scenario is long, when you read this first line, you are okay. Second line, third line, okay. When you read fourth line, you forget these three. When you come here, you almost 90% you forget this. And last 2-3 lines, you forget everything. Right. So this is 10 line scenario, right? So in 9-10, you forget first eight. So don't get confused, don't worry. Just try to understand what exactly they wants to ask you. So concentrate on the final question. So final is, which of the following is the most appropriate next step in the management? That is what they wants to ask. This is tip from my side. So keep this word, most most appropriate next step in the management. Now let's go to the question. 22-year, quite young old man develops agitation, restlessness 1 hour after undergoing uncomplicated laparoscopic appendectomy. So he did, 22 years boy developed appendicitis, probably acute. They underwent for laparoscopic appendectomy, and that is fortunately uncomplicated. There was no complication. But what he developed after this, what time frame? 1 hour after he developed restlessness and agitation. Go ahead. He also has a tremor, diffuse sweating, headache, and nausea with dry heaves. Intraoperatively, there was approximately 100 ml of blood loss, and urine output was 100 ml, and 1 liter of ringer lactate solution was administered. His pain has been controlled with the morphine. He was admitted to the hospital 3 days ago, has not eaten for 18 hours. He has no history of serious illness. He has experimented with the intravenous illicit drug. He drinks 3 beers and 2 glasses of whiskey daily during the week and more on the weekends with his college fraternity. He appears anxious. His temperature is 99, pulse is 120, respiratory rate is 90, blood pressure is 142 over 90. He is oriented to person but not to time and place and keeps asking his father and keep asking if his father, who is not present, can leave the room. Mucous membranes are moist, skin is warm. Cardiac examination show tachycardia, yes, because pulse rate is 120. Regular rhythm, lungs are clear on auscultation, abdomen has 3 pot site which clean and dry bandage. His hand tremble when his arms are extended with the fingers spreads apart. Which of the following is most appropriate next step in the treatment? So my dialogue is diagnosis, then treatment. So think of diagnosis. They are asking the
So this,
treatment, directly treatment without diagnosis. So what you do? Administer intravenous propranolol, administer because there is a tachycardia, no, 120, so it reduces the pulse rate. Beta blocker, propranolol. All lol is a beta blocker. You need to know all beta blocker. Propranolol, atenolol, metoprolol, parindrolol. So, so all lol is a beta blocker. Intravenous lorazepam, administer intravenous naloxone, administer intravenous dexamethasone, maybe hypoglycemic, administer 5% dextrose and half NS, and administer the intravenous dentrolene. Excellent. So, what's the diagnosis?
Delirium tremens, sir.
Delirium tremens. Delirium tremens. Let's see what other experts are saying. Yes, one diagnosis is delirium tremens. What other differential diagnosis? Yes,
Sir, is it tachycardia and fever? Is it related to shock, sir?
which shock? Shock. So there are 5 type of shock. You decide which shock. Cardiogenic shock, hypovolumic shock, neurogenic shock, anaphylactic shock, and septic shock. This is what I know. 5 shock. Any other shock remaining?
Sir.
Yes or
His
no?
abdomen and 3 ports are clean and dry, so septic shock chances can be less. Neurogenic shock because his skin is warm and membranes are moist. It cannot be hypovolemic because the mucous membranes are moist. So
So, so
neurogenic.
one differential point, shock. All shock can cause, all shock can cause tachycardia except one shock, which cause bradycardia. Exam question.
neurogenic.
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 Neurogenic shock can cause bradycardia. Here
Yes,
we
sir.
have a tachycardia. So now do you think it is a neurogenic shock?
No, sir, it cannot be neurogenic shock.
So it's gone, right?
So
Just for
this
your
is
knowledge.
alcohol withdrawal complication, delirium tremens.
Alcohol withdrawal complication. So what is alcohol withdrawal complication? Can you little bit elaborate?
Sir,
What
it
do you
usually
understand by
occurs
alcohol withdrawal?
in people with chronic heavy alcohol use when they are withdrawing from alcohol, usually following a hospitalization, uh, probably on day 2 or day 3 after the last
No?
drink, they can develop these kind of complications
Okay.
of
What is
confusion and
is
disorientation,
there is
agitation.
there any name for this complication?
Yeah, it is delirium tremens.
Okay, this is the delirium tremens. And what happens in delirium tremens? Whatever it is mentioned here, they develop, right? What is the treatment
Yes.
of delirium tremens?
Sir, I think we will administer
Neurologic.
lonazepam IV.
Sorry, what you want to administer?
Lonazep, sir, lonazepam.
Lorazepam. What is
Uh,
lorazepam?
it's a benzodiazepine.
Benzodiazepine. How it will help to these patients? So, say for example, you give it lorazepam. What happens to the patient? You get my question? Yes or no?
Yes, yes, sir.
We had given, right? But what effect you are looking for this lorazepam? After going into the body, what lorazepam will does to the patient? How it helps to the patient? That is what we want to know as well. No? When I have 104 fever, you administer me 1 gram paracetamol intravenous. My fever will go on. So how it's helpful to me? Sir, your
Sir,
fever will
it
go away. You are fine.
sir it has it enhances the effect of GABA, I think.
Sorry, what it costs?
So it acts on GABA,
What is GABA? What is the full form
gamma.
of GABA?
I don't exactly remember, sir. It is gamma
Sorry, sir.
aminobutyric acid.
Uh, So
It's
you
the
must know.
inhibitory neurotransmitter in the brain.
You need to know full form of TCA. You need to know MAO inhibitor. You need to know SSRI. Need to know GABA. All form you must know being a doctor. Is that clear? Yes or no? If you don't know,
Yes,
go and read it. Is that clear?
yes, doctor.
Tricyclic antidepressant. Mono. Anyone?
Monoamine oxidase inhibitors.
Monoamino oxidase, selective serotonin reuptake inhibitor, like that. So there are long ACH, ACTH. We should know, though it is a simple thing, but we must know, na? We must know being a doctor. Anyway, so what exactly GABA activity is what? What do you mean by GABA? Where is the GABA in our body? Where the GABA is secreted? What is the role of GABA in our body?
It's a neurotransmitter, inhibitory neurotransmitter in the
Inhibitory
brain.
neurotransmitter in the brain. Okay, what is do when you give lorazepam? Lorazepam does what to the GABA and what the GABA does to the patient. Is that clear? What's my question is?
Yes, yes, doctor.
Wonderful. So no worry. Don't worry. It's little tricky, but you need to know being a doctor. We don't need to be average doctor. We are a super doctor. So answer for this questions is administer intravenous lorazepam. Alcohol activates GABA inhibitory receptor, right? And chronic alcohol use downregulate GABA receptor. The abrupt cessation of the GABAergic activity or alcohol in a patient with downregulated GABA receptor causes neuronal hyperexcitability, which is responsible for the manifestation of the alcohol withdrawal, including alcohol withdrawal deliriums. This condition may be lethal and must be treated urgently. The first line therapy for alcohol withdrawal deliriums is an intravenous benzodiazepine. One of them is lorazepam. Benzodiazepines are GABAergic activity agent and counteract the neuronal hyperexcitability, or in simple way the all symptoms related with the alcohol withdrawal, which are given here completely clear cut, right? So alcohol withdrawal, alcohol dependence, alcohol toxicity. Go and read all the three chapters, all three different answer, all the three little different understanding. What is tolerance of alcohol? So alcohol related chapter you must go and read it. Half of the world is drinking alcohol and lots of questions related with alcohol, alcohol withdrawal, delirium tremens, Wernicke's encephalopathy, alcohol related liver disease, eventually this alcohol related cirrhosis of liver, alcohol related esophageal varices, alcohol related gastritis, alcohol related brain or encephalopathy, blah blah. So there is long list. So to go and read the alcohol chapter for your understanding, right? So it's very important. So I think I will stop it here. That's all for today. I spoke for almost uh, an hour and a half. So we have few questions to discuss, but let's compile with the next time. So thank you very much all for joining and giving the kind attentions and interaction and participation. So I would like to get little quick feedback for those doctors who joined the first time or those who are absolutely new. How was the session? How was the learning? How was the mind thought process now opened up, or new gateway of triaging the questions? What's the experience? Quickly, please.
Uh, Sir, I'm Dr. Safa. I'm first time here. I recently subscribed, and although we know the answer, our mind doesn't open to it. Especially there are two, three options, and then like especially when you said that the confirmatory diagnosis, especially in the thyroid, when you said the confirmatory diagnosis or the next step of diagnosis. So these are the very minor words which only you can help us to guide so that we can choose the correct option in that. Otherwise, FNAC would have been the confirmatory diagnosis for the thyroid nodule. But the question was, what is the next best in step of investigation? So all this only with your guidance, sir, we can
No,
help
no,
out.
mine is always there. Feel free to call me anytime. I try my level best to communicate with each and everybody. Probably, I mean, old guys knows. But anyway, thanks for your feedback. So this is all minute things. So what my take home message? Read the question for very well. Read the question very well. Don't jump to the answer. In even exam, we are get panic. Sometimes five questions are so toxic. First one, two, three, four, five. Then our mind is gone. Don't lose your mind, try to concentrate what exactly they wants to ask. Initial investigation, different answer. Based investigation, different answer. Diagnostic, this investigation, different answer. Confirmatory investigation, different answer. Prognostic investigation, different answer. Believe me. So not just the investigation or these things, right? Based is different, initial is different, most sensitive, specific different, prognostic difference, right? So you need to catch the word, what exactly they wants to ask. Yes, and you did not interacted today. Yes, anyone else? Anyone else? Hello.
It
So
was an
now
excellent
listen.
session, sir.
Thank you very much, Mohan sir, for your kind this feedback. Now I would like Dr. Amutul, who recently cracked the exam, probably day or 2 days back. So she can little guide or she can have the latest experience of her, if possible, just couple of minutes here. Are you there, doctor?
Uh, Yes, sir. Yes, sir. I'm there.
Yeah, so I mean, you appeared the exam recently. You cracked the exam probably easily, so you can share
Not
your
easy.
experience.
It was not easy. At least with a 1 year old, it was not easy. Thing is, I was pretty clueless when I started studying because it has been a long gap after my MBBS. So, the only one thing I would like to say is just trust Dr. Munjal, trust his website, just trust blindly and just study. That's it. He's doing a wonderful job. You're doing a wonderful job, sir. I mean, teaching what some of the topics that we haven't learned in our MBBS, and then upskilling us is also one of very great things to do at this. And, you are already an oncologist. You don't have to do all this. But still you're putting so much effort. I think this is a service to your own fraternity for myself. That's what I think. But overall, my experience was very good. Just have to trust him and his website. And during exam is one thing you have to keep in mind is your timing, because the questions, as he always says, are not lollipop questions. They are not one-liners. They're like lengthy, lengthy. Just what he has taken today. This is similar type of questions you get. They're quite lengthy. They give a lot of vitals and all the lab values also. So by the time you read, you finish almost 1 minute only reading the question and options. So you have to be very quick. I was panicky in the first half of the exam because I was not having enough time. I was calculating how much time I might need for the next 75 questions, but somehow I finished it on time. One thing is, whenever you're doing questions, time them. And think that you're doing lengthy questions, you're not doing small questions. What they are on the website, they might seem small. It is actually what he has taken the gist of the question. You will get a long question, but whatever gist, whatever is required to ask or required to highlight, he has given it in the question on the website. So you might feel, "Arey, these are very easy. I can do it." But when you read a lengthy question, you need to pick out the important points from that. So you need to be quite, quite frequent in reading the questions. You need not read the entire subject. Do keep doing questions, keep doing mock tests, time your tests. That is the only thing I can say, and just trust him. That's it. Trust the process. And some of the classes have been great, sir. Especially Dr. Mehdi's classes, ECG and ABG classes. They were excellent for me because those topics were always a question mark for me, even when I was doing MBBS or
No, no worries.
maybe.
I'll tell the Medi to take one
Yeah.
lectures on ECG and ABG and little more tricky things along with hematology. Anyway, somebody has any hematon, that is my core subjects. I'm not a cardiologist or gynecologist, but I have a good skill of teaching, coaching for many years, so I'm just into it.
Sir, but you're doing great job in cardiology, sir. Seriously, you're doing a great job in cardiology. Might not be gynecology, but cardiology, you're excellent with whatever you're teaching.
Fair enough.
That itself is enough for us, at least on our MBBS levels. We are not going on a super specialty level. Whatever you're teaching is enough for exam.
Fair enough. Fair enough. Thank you very much, Dr. Mutul Hafiz, for your wonderful tips to the all students. Probably that will helps yours to colleagues and will help to improve the further things. Anyone, any Dr. Aksa, Dr. Adila, Dr. Afrin, lot of people, Dr. Nauman, any comment on just general? I mean,
Yes, sir. Thanks a lot for the wonderful session as usual. And I also totally agree with the fact that even though we have read these topics quite a lot of time during MBBS, after that also for other examinations, but the way you approach the topic and the question, singling out the MCQ choices and coming to a diagnosis by striking out the remaining MCQ choices. That is something that's a skill that I think you are helping us in developing, which will also help us in future examinations that we plan to take, especially like PLAB and MRCP.
great, wonderful. No, I will be your coach. Don't worry.
Yeah, sir. After I get done with this, that's the plan. So,
Yeah. At least for
inshallah.
hemato-oncology, yes.
And that
Great,
is the most
wonderful.
troubling topic for me. I don't know, somehow hemato-oncology, I think after I went through your lectures, the concepts became pretty much clearer.
No worries. So I have a lot of oncology, hematology lectures on YouTube. It's a free access, so
Yes,
try to
yes,
utilize your things. And in between, if you have any
definitely.
queries, feel free to directly message me. So thank you very much for
Sure,
your
sir.
feedback. Yes, Dr.
Yeah, thank
Nana
you for your
Perry,
time.
you are
Yes,
welcome.
sir.
Yes, Nana Perry, Safa, Samuel, Savita, any feedback? Shana, I think you also joined first time.
Hi, sir. Actually, this was my first mock test exam. I mean, appearing for this one. So,
Wonderful.
yeah, it was a great experience, and I have never thought of going onto a question like this way. So, it was first time for me, and I hope that it'll help me in future in solving more questions also. And
Great.
the way of ruling out the options and getting on to the correct answer is also really it's excellent one. So yeah, it's a good like I'm looking forward more towards more mock test also.
Every Sunday is there, doctor, without failure. Don't worry. I'm not taking any leave.
Yeah.
Believe me. I'm a sincere
Okay, sir.
doctor.
Yeah. So I'll be getting means doing more mock test also.
Fair enough. It's there on the website, subject wise, everything is this all questions are on website, nothing new, but I'm just way of presentation is bit new. When you read, it's different. When I explain, it's different, right? You read
Yes,
100
sir.
times thyroid nodules, you
True, true.
100 times read acute coronary. But when we go in detail, try to understand various things, and this probably will nobody will forget now because we
Yeah.
discuss a lot, right? So many questions we can sort out in a one question. So we need to understand the basic. If your basics are clear, then probably good time. What we do usually directly jump on the answer. We don't probably read the question well. So by my experience, try to give maximum time on reading the question, trying to understand the questions, what exactly they are asking, and try to interpret whether your answer is correct or not. Another important tips is favor and not favor, right? So point
Yes, sir.
favors, point not favors. So if you exclude even point not favors, you can reach to the diagnosis. You understand? You rule out
Yes,
A
sir.
is not answer, B is not answer, 3, C is not answer. So what is the answer? Then D is the answer. That's it. Even though you don't know the answer, you can reach up to the correct answer. Why? Because you ruled out this is not there, this is not there, this is not there. You understand? So
Yes,
this
sir.
skill will develop by doing lots of exercise, practice, practice, practice. It won't come overnight, but once you do 1 week, 2 week, 3 weeks, probably end of the 4 week, you are like very much confident about many things, right? But you need to implement in your practice in day to day.
Yes, sir.
Yes, great, wonderful. Thank you very much, Sana. Keep in
Thank
touch
you,
and
sir.
join
Yeah.
every Sunday mock test. I already added you in the group, so you get all notification.
Sure, sir.
Yes,
Sure, sir.
great. Yes, Safa and Samuel, any comment, and then we'll catch up and close. Nana Perry, Joanne, Jamila,
Sir, I
Hiranthi,
first,
lot of doctors.
sir, Mustafa, I was the first one to comment.
Yeah, oh, great. Sorry. Thank you very much. Yes, Jonah, Jamila,
Thank you, sir.
Hiranthi.
Thank you, sir. A great mentor, sir. I'm lucky that we have a person like you. And as doctor mentioned, skill and a process we have to trust. So thank you so much, sir.
You're welcome. Okay, so anyone else last, or we'll close up the session? Anyone? And you there? Fine. So thank you very much, and
Thank you,
keep
sir.
in touch. We'll catch up with the next session. Thank you once
Yes,
again,
sir.
and try to solve the maximum MCQ and read all the topics once again. These are the so important and all high yield things, and I will come up with the next uh, mock with all different. So don't never ever think that questions are same. 100% all different every time different, right? So prepare well yourself, and we'll see you in the next class. Thank you very much.